Okay, talking more about the brain. So here's a basic kind of brain anatomy and physiology review of the brain, different areas that you'll need to know, like the Broca's, which is the speech area. You have auditory, different auditory areas, and then the Wernicke's area, which is another posterior speech area, visual area, sensory area, kind of getting a basic idea of those things and where they are. Okay, so Broca's area on left side towards the frontal temporal area. This is responsible for motor speech, controls movement of tongue, sips, and vocal cords. Wernicke's area on the left side posterior, responsible for sensory reception and understanding. Okay, so when we talk about cerebral vascular accidents or CVAs, we call these a stroke. There's a movement to switch these to brain attack, because when somebody hears heart attack, it's like, oh my gosh, this is an emergency. We need to call 911, right? When people hear stroke, for some reason, it's not associated with an emergency. So there is a movement to switch this to a brain attack because it should be emergency. This is a disruption of blood supply to the part of a brain. And physiology, TIA versus CVA. So a TIA is the transient ischemic accidents. So TIAs, with that keyword being ischemic, means the brain is going without oxygen, but it's still reversible. People can go through TIAs that it's either caused by a blood clot, very small one, or maybe vasospasms happening, something like that. And then, after a period of time, they get better, like 20 minutes or whatever. But they can lead into like the big CVA, so it is important to monitor those. So I've got TIA there. I guess I've been kind of just reading. Warning sign of a major CVA coming. Usually lasts less than 24 hours. When I had, patients in the nursing home, they'd last like 20 minutes or so, and then the person would be just totally normal, had no idea that anything even happened. No permanent damage because it is ischemic. Assessment: dizziness, loss of vision in one eye, numbness, weakness, especially like one-sided, one arm, one leg, one hand or something, and then aphasia, having difficulty speaking. CVA, there's different types of causes. Thrombus, which is a narrowing or inclusion of a blood vessel. Embolic, which is a blockage by a clot. And hemorrhagic. You can have intracerebral, which is bleeding in the brain from a small blood vessel, or subarachnoid, which is bleeding in an area, often due to a ruptured aneurysm. Okay, risk factors, modifiable. So smoking increases the risk for CVA by 50%. High cholesterol and excessive use of alcohol, cocaine, and heroin also contribute. And then oral contraceptives puts people at higher risk of a cerebral vascular accident. Non-modifiable, so things people cannot change. African Americans tend to be more at risk for having a CVA, hypertension, obesity, diabetes mellitus, atrial fibrillation, and atherosclerosis, which are those plaques that develop. Assessment, it depends on where it is in the brain. We go back to this picture, it just depends on where at here and how bad it is. So, okay. Was I here? And assessment, there we go, that's where it was at. Got through here's assessment. So left side of the brain manifestations, right-sided weakness and paralysis. Okay, it's going to be on the opposite side. If it's on the right side of the brain, then you're going to have left-sided weakness and paralysis. Acute difficulty with speech, visual changes, dizziness, headaches, motor weakness. Hemorrhagic events can occur without warning. Rapid evaluation of respiratory, cardiac, and neurologic exams. Effects of a stroke: hemiplegia or paralysis of one side, aphasia, which is difficulty expressing or understanding spoken or written words if they occur on the left hemisphere, neglect, which is the inability to recognize one part of the body, dysphagia, which is difficulty swallowing, hemiopsia, which is loss of vision toward the hemiplegic side, and ataxia, which is difficulty with muscular coordination. I think I might have all those words. Freaking out. Okay, I think we're back. My computer was kind of having a moment there. So here's all those words again. Okay, and what I would do is I put these on a flashcard set. Aphasia, so complete or partial loss of language modalities, whether it's reading, speech, writing, or understanding speech. Does not affect intelligence, caused by damage to that left hemisphere. Damage to that Broca's, you know what to say but can't find the words needed. Can be hesitant and frustrated to communicate. Receptive, so problems and they don't understand what you're saying. Is damage to the Wernicke's area. Speech sounds normal but cannot make sense of it, unable to comprehend spoken and written. Often will have incoherent speech. These people are generally not frustrated. Global is a combination of expressive and receptive. So when we say expressive, this is the ability to communicate, like to talk and, you know, participate in a conversation actively. Receptive is being able to listen, understand, and take it in. So you have to have both ends for a communication conversation. Dysarthria, this is difficulty in speech caused by paralysis of the muscles that control speech. All right, right-sided hemisphere problem. So assessment, left-sided hemiplegia, like I talked about, left visual field deficits, spatial perceptual deficits. So they lose themselves in time and space a little bit. They don't know how far they are from something. Denies or is unaware of these deficits, has poor judgment and easily distracted and can be impulsive. All right, left hemisphere problems, right-sided hemiplegia, so that right side is going to be weakened or paralyzed, sorry. Right visual field deficits, aphasia, aware of deficits, typically impaired intellectual ability, slow, cautious, very frustrated over losses. Like they knew they had this at once, but now they don't have it, and they're very much aware of that. When we talk about right visual field deficits and left visual field deficits, this is, you know, if it's the left side of the brain, then it's the right eye that's affected, and they'll be able to see like the left, but they won't be able to see the right. So if you have them like even draw a clock, like all the numbers are going to be on the left. They're going to be missing things on the right. It's very interesting. Diagnostic, CT and MRI, we've talked about quite a bit. Carotid ultrasounds, these look at neck arteries and, you know, trying to measure that atherosclerosis and things like that. Cerebral angiography, this is x-rays with contrast to visualize arteries in the brain and diagnose aneurysms. Transcranial Doppler, this is an ultrasound of intracerebral vascular areas. PET scan, this identifies tissue damage. Lumbar puncture, not routinely done with strokes, but can detect blood in the cerebral spinal fluid if it is. EKG, that, you know, shows the source of an embolism maybe. And EEG monitors brain waves and brain activity. All right, intervention. So management of blood pressure is going to be key. If it's because of a high blood pressure, you know, typically we're going to leave the high blood pressure alone unless it's a hemorrhagic stroke. If it's a non-hemorrhagic stroke where, you know, it's like a blood clot kind of thing, then this is a protective mechanism for this type of stroke to force that blood through. So if it's a hemorrhagic stroke, then it's just bleeding out into the brain, right? And then we got to get that blood pressure down. But if it's not due to that, then we might just allow that higher blood pressure because we know that that's kind of compensating. It's trying to force that blood through where it needs to go. Head position flat unless there's a large hemorrhagic infarction, then elevate to reduce the ICP. Fluid volume, medications, antiplatelets, only in ischemic strokes. You know, we don't want to do that with hemorrhagic. You know, aspirin, Plavix, warfarin, heparin. Thrombolytics, these are only used in ischemic strokes again, not hemorrhagic. Time frame is critical. Within 3 hours of the first symptom, assess for bleeding, right? Any thrombolytic, we're always assessing for bleeding. Osmotic diuretics, especially that mannitol to get fluid off the brain. Monitor I's and O's with any kind of diuretic. Anticonvulsants, phenytoin, this is given to prevent or control any seizure activity. Consequences, neuro, watching for increased intracranial pressure. Respiratory, we worry about the development of pneumonia because sometimes the respiratory rate and depth can be altered. We worry about E's and DVTs. Cardiac, arrhythmias are common, especially if there is a blood clot or something like that involved. Safety, we worry about falls if they get up to move. Skin integrity, you know, worrying about pressure ulcers. You guys know this, reposition every 2 hours. Pain. Pain may show other types of consequences that might be happening. If this was due to a trauma or an injury, then, you know, we might see other manifestations of that. And then mental status can cause depression. We really want to help them in examining their feelings. All right, how much time do I have left? Okay, I'm going to keep going here. So CVA should be a lot of review for you guys. You've had that before, that content. Seizures, this is something kind of new for you guys. So seizures, this is a brief disruption of brain function caused by abnormal synchronization of electrical activity in the nerve cells of the brain. Okay, so just like we talked about cardiac and watching those electrical impulses, you have the same electrical impulses happening in the brain. And if they're not working the way they're supposed to be, a seizure can manifest. Epilepsy is the chronic recurrent pattern of seizures. So if you have one seizure and never have one again, that's not epilepsy. Now, if you have seizures that come daily, every other week, every other month, something like that, then that's epilepsy. It's when you have a pattern of recurrent seizures. Etiology is commonly unknown. There are some correlation studies with birth trauma, hypoxia, infection. Drug abuse is a big one. Fever is also another big one. Congenital defects that involve the CNS. All right, so there's a few different types of seizures. So there's generalized seizures that involves both hemispheres of the brain. Tonic, and then I actually have that spelled wrong. Clonic, there we go. Tonic-clonic and absence are two types of generalized seizures. Partial, which start in one area of the cerebral cortex. These involve simple partial seizures and complex partial seizures. So we're going to go into what each of these are. Okay, so seizures, the first type I'm going to go through is the tonic-clonic. This is most common in children and adults. They develop suddenly and follow a pattern. So an aura, this is an unusual sound or taste or visual distortion that occurs immediately prior to losing consciousness. So an aura is kind of like that precursor that somebody's going to experience, that they're like, oh, I'm going to have a seizure. You know, it's that kind of warning sign that they can get. And it can be anything. It's some kind of sensory stimuli that they're going to get. Tonic phase, this is the muscle rigidity where all their muscles are flexing. And then the clonic phase, this is the jerky movements that the muscles alternate between contracting and relaxing. Post-ictal phase, they can be unconscious up to 30 minutes, may have headache, muscle aches, and fatigue, may sleep for hours after a seizure. And then amnesia of the event is very much common. All right. Absent seizures, these occur most frequently in children. They go unnoticed and resolve by adolescence. They may appear as though they're daydreaming. They may have a blank stare, eye fluttering, or lip smacking. All motor activity is usually stopped, and they last only for about 5 to 10 seconds. I tell you what, my middle kiddo, I know I talk about him a lot, but when he was like 2, my sister was living with us at the time. She had just moved back from Colorado, and we both noticed that he would like totally, you know, just daydream. He's looking right past you and he'd be like, Ian, nothing. And then about 10 seconds later, he kind of flutter his eyes a little bit and be like, oh, were you just talking to me? You know? So he might have had seizures. I don't know. We haven't seen that in a very long time, but, you know, just like we kind of talk about, they generally occur in children and resolve on their own.